Today we look at how to help patients live better lives, with or without recovery from mental illness. Welcome to the Carlat Psychiatry podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kelly Newsom, a psychiatric NP and a dedicated reader of every issue.
In 1964, Joanne Greenberg published a book about her experience with mental illness. I Never Promised You a Rose Garden would go on to sell millions of copies. It was adapted into a movie, a play, and a hit country song. The title comes from something her psychoanalyst, Frieda von Richtmann, told her when she was a patient at Chestnut Lodge. I never promised you a rose garden. It echoes Freud's comment that the goal of psychoanalysis is to replace neurotic misery with ordinary unhappiness. And why do we start a podcast on flourishing on such a dour note? Because we're about to look at how to help people with mental illness lead more fulfilling lives, and I want to keep this grounded as we go forth. Life is hard. Mental illness is hard. Full recovery isn't always possible. And part of recovery is learning to ride the ebb and flow of ordinary unhappiness, something we all do, but is a little more difficult when the symptoms you're used to seeking medical treatment for, anxiety, depression, insomnia, bear an uncanny resemblance to the symptoms of everyday life.
Today we're going to look at what science has found about flourishing and how we can help our patients use that knowledge to convert some of that ordinary unhappiness into joy, inspiration, and contentment. It's the final coda to our interview series with Margaret Chisholm, who wrote about flourishing in her book, From Survive to Thrive, Living Your Best Life with Mental Illness, which won a Nautilus Book Award. In an earlier podcast, Dr. Chisholm described the 4 perspectives she uses to assess the problems that patients bring. The medical model, which includes DSM disorders, the dimensional model, which includes personality traits, the behavioral model of habits and addictions, and the life story perspective, which looks at the meanings patients make of key life events. She began by clarifying that flourishing is a very different concept, one that looks at possibilities, not problems, one that is focused on the future and not the past.
The thing about the life story perspective is it's retrospective. It's looking backward in time. These pathways are really looking forward in time and thinking about what is somebody's goals, what's going to keep them moving forward, getting a little better each day in some aspect of their life. The perspectives model is more focused on psychiatric problems, and the flourishing model is more focused on living your life to the fullest potential, regardless of whether that trajectory has changed because of the psychiatric problems or not. Maybe their hallucinations and delusions aren't going to get any better, but the quality of life can still keep improving as they form close social relationships, take care of their physical health, find some meaning and purpose in a job or other activities. I just don't think being satisfied with a non-flourishing life, a languishing life, is acceptable for any of our patients. I would not accept that for any of my patients. The example I often give is a patient with addiction who is pregnant, and I worked for 10 years at the Center for Addiction and Pregnancy, and I'm able to help her stay off drugs during the pregnancy, but then after the pregnancy, there's less positive reinforcers, less motivation externally, and so we need to strengthen these pathways, like if she's burned bridges with her family members, needs to kind of reconnect with those, needs to get work or as a positive reinforcer that would compete with the drug use, continue education, reconnect with the community, whether it's a faith community or connect with a new community like AA or NA. So all those things are going to be necessary, not only to help maintain recovery, but also be able to go beyond the problems that have constrained her towards, this new life, a new path forward.
Let's pause for a preview of the CME quiz for this episode. Earn CME for each episode through the link in the show notes. Which of these is one of the 4 ingredients to flourishing as described by Dr. Chisholm? A. Education. B, exercise. C, health. D, optimism.
Tell us more about your model of health.
So a lot of my work has been informed by Tyler Vanderweel's model of flourishing. And he wrote a JAMA paper in 2019 called Reimagining Health. Basically, he also is making explicit things that we know implicitly, which is that leading your best life has several domains. The ones that he's talked about, which is happiness, life satisfaction, mental and physical health, meaning and purpose, character and virtue, and close social relationships. Philosophers have talked about for a long time when considering what it means to lead a good life. He also talks about financial stability or material securities. So, those are the components I think most people would agree to leading a good life. And what Tyler has done is he's an epidemiologist who studies these large longitudinal data sets. His area of expertise is causal inference. So he's drawn causal links from these data sets between the pathways of flourishing and these domains of flourishing. And he's found that the 4 pathways to flourishing are, not surprisingly to all of us who work with patients, the 4 pathways to flourishing are family, community, work, and education. And he specifically talks about religious community, which is what the epidemiologic data sets often ask people about. So the family is sort of obvious to us, right? When somebody needs support in getting better from their illness, it's really important to getting well and staying well to have the support of family and have those relationships, somebody that cares about you, somebody that, you matter to. If you're dead or alive, it's going to matter to them. Really important. It's important for people in, recovering from addiction to have that supportive family. Often they burn bridges, so they have to rebuild those. We consider each of our patients from these 4 pathways. What is the strength of their family ties? What ties do they have to the community? Do they need to be in AA or NA or a supportive community? Would it benefit them to reconnect to their faith community? We look at the strength of their work. Do they have meaning and purpose in their work? Is there someone at work that depends on them? In terms of, say, drug addiction, which I'm addiction medicine certified, so I keep going back to addiction. But in terms of drug addiction, thinking about positive reinforcer that work is and how it can compete with drug use. If somebody is having meaning and purpose and a pleasurable experience socially at work. And then the 4th pathway is education. It's important for people to be able to read and to be able to learn, whether it's formal learning or informal learning, to engage with the world that they live in, brings meaning and purpose. It's an area where people can meet other people, obviously. These pathways are relevant even to somebody who has a disease, right? If they have schizophrenia, their trajectory might be a little different than what had been expected. Somebody who got ill when they were at MIT, for instance, might have been on one trajectory. Now they have this very serious illness. And even though they might not be on the same trajectory, they can still lead a flourishing life. They can still lead a good life. But it's usually through these pathways, having supportive family, being part of the community, getting meaningful work, and attaining the educational level that they desire or are capable.
There's a lot of patients that they've reached the limitation of psychiatric recovery. They're not going to get better with the new antipsychotic, and what can we do for them further? Is that how this works?
Yeah, absolutely. First of all, I would never give up hope that somebody's not going to get better with new medications and with time. But I do think that as somebody is recovering or in a maybe very slow state of recovery from an acute major mental illness, they can still work on these pathways and draw meaning from the relationships, whether it's at a partial hospital program or through a job training program or through a sheltered workplace or by engaging with the NAMI community. There are many ways that people can lead meaningful lives even when ill.
If they take on those pathways, whatever medication they are on is likely to work better.
Absolutely. Well, and I think it would be more likely, about a study about this, so I'm just talking off the top of my head, but I do think you would be more likely to take your medication if you were leading a good life. There was somebody waiting for you at work, and if you didn't take your medication, you might not be well enough to go to work.
Opens up a whole new way of talking about adherence, I imagine.
Well, I think about that a lot in the non-psychiatric medical specialties. If you have somebody who's not taking their insulin for diabetes, and then you look at their life and they're living alone, they have no family, they have no job, they have no place to be, nobody's depending on them. Why would they take their medication? If they're not leading anywhere near what any of us would agree upon as a good life, you have to work on those things first and then give a person a reason to take their medication. I think it's very relevant to all of medicine.
I wonder how you open up education for patients, because I imagine a lot of them are going to think of that as whether or not they have a degree. And, I already did that. I got my degree. Like, how do you open that in the broader sense?
Yeah, I really think it's about learning more than education. And I think to be able to learn, I do think you need a basic education, a high school education. You need to be literate. But education can mean a lot of different things. It doesn't mean a 4-year college degree or 2-year college degree. It could mean learning a new skill, learning to cook, learning to garden. It really is about learning in a way that engages the mind, that brings meaning, right? And sometimes these learning goals can also overlap with community goals, right? Because you can be, through learning a new hobby or skill, you can become part of a community of other people interested in that.
A few months ago, I saw a paper suggesting that we view isolation as a disease because it's associated with so many adverse health outcomes. Clearly, if it is a disease, there's an epidemic going on. What's your take on that? Isolation.
Yeah, so this is the flabby thinking, calling everything a disease.
The disease model.
The way I define disease is it's a syndrome. It's a cluster of signs and symptoms that run a course together that can be best understood as emerging from a broken part or function. So isolation, I don't think would meet that. I would say that isolation is best understood from the life story perspective and is different for different people. This is the interaction between the dimensional perspective and the life story perspective. The people that have done the best during the pandemic are people, it's not the introverts, which is what people might think. Studies actually been done on this. It's the conscientious person. They did the best because they could self-structure their time.
That's news to me. But that does make sense. I noticed my patients that were doing better were all going for walks every day outside. I thought of it as nature, but it's also conscientiousness. You're right. Yeah.
Well, if you can devise a schedule for yourself, you don't need that external work structure or whatever social structure that was imposed on you. I think it makes it a lot easier to cope with these situations. So again, that's how I would see it. I would see it as best explained by the life story perspective, which obviously has interactions with other things and could lead to a disease. It could be a stressor for you, depending on what your personality is. We know that increased stress makes it more likely to precipitate an episode of affective illness or something like that. So, or it could be, you're socially isolated and you're drinking more. I've heard that happens.
So for isolation, you might say good target there, but wrong lens, wrong perspective.
Exactly.
Margaret Chisholm is a professor of psychiatry at Johns Hopkins University. She has authored over 150 scientific papers and 2 books that explore the perspectives of psychiatry. One for professionals, Systematic Psychiatric Evaluation, and one for patients, From Survive to Thrive, Living Your Best Life with Mental Illness. A shortened version of this interview appeared in the March 2022 edition of the Carlat Report and is available online. Want to keep up with the latest in psychiatric research? We post new studies in the Daily Psych feed. Search for Chris Aiken MD on LinkedIn, Twitter, Facebook, and that new one, Blue Sky. is the first glimpse of the trials that inform this podcast. And thanks for tuning in and helping us stay free of industry support.
Thanks for watching. Hit subscribe if you enjoyed this content. And to earn CMEs for listening, head on over to thecarlatreport.com/podcast.